Good morning. Now, I think we're able to continue with Dr. Mumford.
Yes, Dr. Mumford returns, Paul.
Good morning, Dr. Mumford.
Good morning.
Now, this is not your first attendance, and you'll be familiar with our procedure. Before asking Mr. McIntosh to begin his questioning, I understand you're prepared to affirm.
Yes.
Sitting where you are, can you repeat these words after me? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
As you will have anticipated, we plan to take a coffee break at about 11:30. But if at any stage you want to take a break, just give me an indication. And at the risk of repeating what I probably said to you before, it's very useful for me if you keep your voice up a little bit louder and slower than you would in normal conversation.
Thank you.
Right. Mr. McIntosh.
Thank you, my lord. Thank you for coming back, Dr. Mumford. What I'm proposing to ask you about is in three areas. I think I had intended to ask rather more questions about the HAD report than I previously did, but I don't now feel the need to. But I'm going to focus on three topics. One being the work of Mr. Mukherjee and the changes he's made to his report in recent days. Secondly, a discussion about risk and the concept of how risk and the concepts of safety relate to each other in terms of risk management based on your report on that subject. And thirdly, just intends to see where your original conclusions given in your original report and your evidence last year with Ms. Dempster have evolved, if they have, since then in result of the HAD report and possibly Mr. Mukherjee's work. I'm proposing to do that latter part after lunch. Hopefully it'll form three neat parts during the day. If I might turn to Mr. Mukherjee's recent evidence on Wednesday, did you, on Tuesday rather, did you have the opportunity of watching his evidence or reading the transcript for it?
I saw some of it and I read the transcript.
Thank you. How much of Dr. Traput's evidence did you see the previous week?
A little bit.
A little bit. Now, if we might start by a report produced by Dr. Traput in Bundle 44, Volume 4, Document 1, page 3. Volume 4 or 44? Thank you. So I wonder if you've seen this report before from December. Now, in essence, what did you understand was the point being raised by Dr. Traput in respect of your work?
So my understanding is that Dr. Chaput felt that we had not included, or we'd been very selective in which organisms had been included in the calculations that Mr. Mukherjee did. And then I had taken that into my report and used an inferior data set to suggest what the difference was between the comparator units and the Shehalin unit. Because
the reality is that you're the microbiologist, so the definition of which microorganisms are relevant comes from you, not Mr. Mukherjee.
So originally, myself, Ms. Dempster, Mr. Walker as another microbiologist, and Mr. Mukherjee got together and went through and compared all of the data, all of the environmental organisms that had been identified in several different reports. So in the CNR, in the HPS report, in the data that we had from GGC, and put that together and made sure that Mr. Mukherjee understood which were environmental organisms and which were not. And the reason that we did this is because A, he's not a microbiologist, and B, he had some in his data set that he was trying to include, including things like Haemophilus and Salmonella, which clearly are not environmental organisms. So we just wanted to have that clarity that we agreed on what an environmental organism was. And so we used all of the reports together.
And was there ever a single list setting out all those organisms placed in any of the reports by you, Ms. Dempster, Mr. Mukherjee, or indeed Dr. Walker, as far as you're aware? Single master list?
I know that, I think Mr. Mukherjee had a list, but I don't think that it was that list. I think he had the list of organisms that we found in the Schiehallion unit.
And when you were working on this, was it the inquiry's intention that you, Ms. Dempster, and Mr. Mukherjee would produce a joint report?
Initially, yeah.
Initially. And could it be that I asked you to separate your reports so that you and Ms. Dempster produced what became the qualitative report and Mr. Mukherjee produced the quantitative report?
Yes.
So if we look at Dr. Chaput's paper and, in a sense, take it short by going to page 5 of the bundle, she presents in 2 tables on this page and the next page a list of organisms. Now, what I want somebody to understand is, are you saying that actually she was arguing that there are organisms on this list that weren't seen at Queen Elizabeth that she thought you hadn't taken account of in SID's calculations?
Yes, there are organisms on this list that did not appear in the Schiehallion unit dataset. She is wrong in thinking that they weren't taken into account. SID took all of these organisms into account when he did his calculations.
Would you accept that to some extent the fact there isn't a master list in any of these reports might have been part of the cause for her being wrong in that respect?
Entirely. Yes, in retrospect, that should have been included.
If we go to SID's report, Mr. Mukherjee's, well, we shouldn't call him SID, we should call him Mr. Mukherjee, and I do that as well, and go to bundle 21, volume 1, document 1. And we look at, just might let it load up on my computer. I'll try again, but my computer's now decided to open all the bundles on the computer at once. There we are. So if we go to his report, which is bundle 21, volume 1, document 1, at page 19. I mean, not 20, yes, 19, a table at paragraph 7.1. If we look at his case definition for the first row on the table, which we see the first 3 lines here, so the data specifics column reads, the data is patient infection episodes, and we go over the page, and we go back to the previous page, and the data specifics is Queen Elizabeth, including RHC, and the case definition is gram-negative bacteria, environmental, over the page, and enteric group and fungi, and for comparative institutions, it's the same wording. Might that be, in a sense, the closest he comes to saying it's the same data set, same list of infections?
Yeah.
So if you were to go back to Dr. Chaput's report in volume 4, or bundle 44, which we were looking at a moment ago, and go to page 6, is it your understanding that everything on this list was included in his process, either if it's on this page in the comparator units, or if it's on the previous pages on either the comparator units or the Queen Elizabeth?
And they were included, yes, even the salmonella, which I don't agree should have been on there, but yes.
We take that off the screen. I don't know whether you saw this part of. You wrote a report and response, which is bundle 44, volume 4, document 2, page 19, page 9. And this was prepared in May. Go to page 10. What do you say in page 10? Is this you explaining your answer to a question I asked you in the Glasgow 3 hearing about this issue? In paragraph 4.
Yes. Yeah.
So your evidence in the Glasgow 3 hearing was to this extent inaccurate in that you gave the impression that he had removed organisms from comparative data sites which did not appear in the Schalian data.
At that time, yes.
It may have been the way I asked you the question, to be fair, but you did say that.
Yes. And I hadn't reviewed Mr. Mukherjee's workings at all in coming to that conclusion, which I should have done.
Now, over the next page, on page 11, did you provide a table for the Great Ormond Street comparator infection count?
Yes.
Now, that then prompts another issue, which we'll come back to that in a moment. But what I want to do is to put to you, if we take that off the screen, what my colleague Mr. Connell discussed with Dr. Chaput. Now, he asked her, she'd used the word bias in her statement, and he felt he wanted to ask her about it. And she explored that in some detail. But eventually, I get the impression that she had been concerned that the choice of only looking at the infections, a choice of only looking at infections found in Schalian would expose sort of analytical bias towards or against Glasgow. And I know that's not what was done, but do you understand why she might say that?
I think so. I think, we were asked to look at environmental organisms arising from a particular environment or potentially arising from a particular environment. And so it made sense to us to look at the patients who had been in that physical environment and not spread the net wider to patients who may have been admitted with hemato-oncology conditions but had not been on the Schalian unit when they became unwell with a bloodstream infection. So we were very much looking at patients exposed to the environment.
But your comparison considered all the potential infections, even the ones that, as it were, didn't happen in that location. In the comparison, his comparison rather compared though that subset of the potential infections that occurred in Glasgow with that subset of the potential infections that occurred in the comparator units.
Yeah, and we counted them in the same way.
Right. Now, if we think about Dr. Chaput's then issues with Mr. Mukherjee's exercise, what I wanted to do was, because Mr. Mukherjee explained in evidence that he discussed the matter with you, now ultimately he took the position that in respect of some parts of Dr. Chaput's criticisms, he accepted them, or at least he accepted to work with them for the purposes of his exercise, and in some he didn't accept them. And what I was proposing to do is go through, in a sense, the 5 headings and understand from you what involvement you had in discussions with him. So if we start with, we go back to, go to his report, which is bundle 44, volume 10, which has not yet been put on the website, because we're waiting to add something to it, and we go to page 4. No, not volume 10, sorry, volume 9. And we go over the next page. And the next page. If we go to the one more page. Right, it's about 4 pages further on. Sorry, I haven't got mine on my screen. We go to the annex, which follows after that. After that. There we are. We go to the page 19, please. Page 18. I'll get there eventually. Right, now, what I want to do is look at each of these hospitals in turn. Now, if I understand correctly, Dr. Chaput's criticism was that she does not believe that Cardiff and Vale deduplicated, and Mr. Mukherjee does believe that Cardiff and Vale deduplicated. Did you get involved in that discussion at all?
No, not at all.
No. In respect of Leeds, to one extent, there's the same tension between the two of them. Did you get involved in that discussion?
No.
No. Over the page on page 19. There's then a question around the use of a partial year in 2016 in Leeds. Did you get involved in that?
No.
No. Over the next one. There's then a discussion about whether Oxford deduplicated. They didn't say anything about deduplication, but did you get involved in that?
No.
Now, before we look at Great Ormond Street, Mr. Mukherjee's broad approach seems to have been, we asked them a question in an FOI request that requested deduplicated data. Unless they're really overt that they haven't done it, I will work on the assumption that they did. Is that your understanding of his approach?
That's my understanding of his approach, yeah.
What's your view of that as a sort of practical approach in this field?
I think that there is an option when you put a FOI out, that if you don't understand the data when it comes back, that you go back and ask for some clarification. And I think that possibly could have been done. I mean, I agree with him that, if you ask for an FOI, you try to rely on what you get. But I think that the vagueness of some of the information that came back would suggest that he should have gone back for some clarification.
Do you have any difficulty with him using the data he received for these 3 hospitals for the reasons he used them?
So if they deduplicated further, the rates would only go down, not up.
What effect would that have on the study he was trying to carry out?
So that would lower the mean rate of infection in the comparator units. So that would very much play into suggesting a bigger gap between what we observed in the Schiehallion unit and what was coming back from the comparator units. So I don't think it is, whilst it may have made a difference if they haven't deduplicated, it would not have brought the two any closer together. It would have pushed them further apart.
So if Mr. Mukherjee's position is that for some years there is a statistical significance in the difference, that statistical significance will only have got larger.
Yeah.
We turn to Great Ormond Street. Now, if we can go over the page, do you understand the point that both Mr. Mukherjee and Dr. Chaput are making about these 3 columns provided by Great Ormond Street now that you look at this data set? What do you understand to be the issue, if there is one, around the total episode 14-day column on the right-hand side?
I assumed that was the deduplicated column.
Right.
It is, to the uninitiated in the deduplication, it would suggest that why are there zeros in there? Because clearly there's been an episode. But I would say they're either cases that have already been seen
Elsewhere in the list.
Elsewhere in the list, or have not been, because we asked specifically for data from the hemonc units
Yes.
in these comparators, that if they had the first diagnosis or first blood culture taken in A&E, for example, or a clinical decision unit, that would count, and everything else
would count
taken
in
on the unit
deduplication.
would then have been deduplicated out.
So if you had a
hence the
patient
zeros.
who is received in A&E, they take a blood sample,
Yeah.
and then within 14 days they're on the paediatric hemato-oncology unit, that would deduplicate to 0 from 1.
If they had another blood culture
Yeah.
taken growing the same organism.
Because it wouldn't be necessarily an infection acquired, might not be an infection acquired in the hemonc unit.
That's not the reason.
No.
The reason would be that within 14 days, it's assumed to be the same infection.
Right.
So you don't report it twice.
However, Mr. Mukherjee's evidence was that he was now, for the purposes of the study, proposing to accept Dr. Chaput's view that she should use the right-hand column, and has now used it. Did you have any role in that? Did you have a conversation with him about that before he gave evidence?
I did talk to him before he did that about what that episode 14-day column meant, because and around the zeros and so on, and suggested to him that he needed to look at that and do the calculations based on that column.
Did you know that was what Dr. Chaput was suggesting he do?
Yes.
Right. If we move on through Dr. Chaput's paper onto the next page, the GGC deduplication exercise. Now, it's probably easier to look at the end of this table, which is on page 24. So if I understand what Dr. Chaput has said here, she noticed that the total number of infections counted by Mr. Mukherjee at the Schehallien unit, by his definition, is 187. And after his deduplication, and her view is that 159 should be the figure after deduplication. Did you have a conversation with Mr. Mukherjee about her issues?
I did, because when I read this, I thought I just needed to check it for myself. So I went through the spreadsheet of the 215,000 lines and deduplicated manually for each organism where there was a disagreement between Dr. Chaput and Mr. Mukherjee. And I found that in the majority of cases, I agreed with Dr. Chaput and not with Mr. Mukherjee. So we did have a conversation about him looking at it again. What was the potential reason for him getting a different outcome, and whether or not his coding that he'd deduplicated based on was correct, and that perhaps he should be having another look at it, doing it again.
And he ultimately decided to proceed on what I suppose you could describe as a Chaput-inspired calculation, because of course Dr. Chaput has chosen not to provide an annual figure within 159, but he's now created one.
Yes.
Was that something that you were aware he had in mind when you spoke to him, or was that something that happened after you spoke to him?
No, I really left him to it and suggested he take another look and set him off doing that.
Do you have any view about the idea of him creating a annual number of infections for Schehallien that, in a sense, is inspired by Dr. Chaput's comments, probably not necessarily exactly what she would do, and comes up with a total of 159 as a way to resolve this issue?
It needed to be looked at. In order to be able to look at the rates, it needed to be done on an annual basis.
Now, what would be the effect, or what is the effect, of moving from a group of number of infections in the Schehallien overall rate that was 187 in the original quantitative report down to 159 in I think I invented the phrase, the Chaput inspired rate. Again, thinking about the comparison exercise, what's the effect of that?
It would, in places, reduce the rate of infection in the Schiehallion unit, the observed rate, and bring that closer to the comparator unit.
Is that inevitable? Because I think actually in Mr. Mukherjee's number, there is a year when it goes up.
Well, it shouldn't go
Right.
up because he should have had the organisms in the right year to start with.
Right. Now, if we then,
Although the rate would, the number wouldn't change, but the rate, no, that's not right. No.
okay. If we go to his conclusions, which he set out earlier in this document, go to put it in a chart. Well, it's in page 16, and over the page on 17. No, 16. Yes, that's what I wanted to come across. So this is the paper he attached to the note, but this isn't the paper that he ultimately spoke to. We have that. It's going into a bundle, but it hasn't yet gone in. We don't have that at the moment. Have you looked at his final calculations? The ones he gave evidence on early in the week on?
I've looked at I've seen the paper that he did eventually.
The event we did eventually, yes. Now, I'm looking nervously at my colleague. I've realized I probably haven't told I want to see this document. We'll take this off the screen. What do you understand to be Mr. Mukherjee's final conclusions?
That there remains, after all of the recalculation, including the GOSH recalculation, which has taken the comparator down, that there remains a statistically significant difference in the rates for 3 years, 2016, 2017 and 2018.
Now, I understand that you're not actually in a position to be able to give evidence about whether there is a significant difference. That's not your thing.
Absolutely not.
No. Is there any other aspect of the data that he produces that remains the same? The charts or the trends or the differences?
I think the shape of the curve remains roughly the same, which is kind of the significant thing, because the shape of the curve is seen in many, many different reports, and shows the increase in rate across those years from 2016 to 2018.
Now, after all that change, what should we make of Mr. Mukherjee's final document? I mean, what I've done is I've asked for him to provide the tables that contain all the numbers applied in the chi-squared p-value calculation. I may have misdescribed that, his statistical exercise. And I've asked core participants we'll get back to them probably today, and I've asked core participants to respond within 2 weeks if they, for example, have any contribution they want to make about that calculation. And I've set 2 weeks because a witness in the Part 3 hearing, I think, could speak to this. And I will deal with the responses when they come in. But other than that issue about the statistical significance of the calculation, what should we do with Mr. Mukherjee's, as it were, final conclusions?
I think they're so similar to the conclusions that other authors, including the HPS and CNR, have made, that they hold some validity, in that the shape of the curve is the same, the significant difference, and I don't think that has changed. But I can understand that there is wariness around.
Well, that's what I wanted to put to you, because I suppose there's two countervailing positions. One is that when an expert changes their mind in response to questions put to them over a period of time, starting last year when he realized that the emission day data he'd been given was only overnight data, and then the changes he made when it was put to him that 2A patients ended up elsewhere in the hospital, and he hadn't taken account of that. And now this. One view is that that damages an expert because they become, to some extent, unreliable. You worry, is there going to be another change around the corner, and therefore you don't give them any weight. Another view, which has to be fair is the one that Mr. Mukherjee has expressed, is that the process of carrying out epidemiology is a continuous dialogue, and you would expect such sort of discussions to take place. It's just, unfortunately for him, in contrast to many of the other reports, we've done it all in public, often in these hearings. Do you have any view on whether either or both or neither of those perspectives have value?
I think there's undoubtedly been a lot of scrutiny on what Mr. Mukherjee has done, more so than other reports which have been brought into the inquiry. I think I was interested in Dr. Drumwright's observations that epidemiology is inherently inaccurate, and that you will always find inaccuracies in data such as this. But I think the overriding factor is that the curve is the same. The increase in infections is seen across all of the reports that we have. But I'm not in a position to say whether or not it's epidemiologically sound, because I'm not an epidemiologist.
What I'm proposing to do is I'll come back to the weight you want to give it this afternoon when we revisit your conclusions from your original report and your evidence from November.
Okay.
We'll also talk about the HAD report, who of course have been through their own journey as well. Let's move on now to a topic that relates to your risk management report. So this is in Bundle 44, Volume 6. And at page 4, it's document 1. We asked you to prepare a report on risk as it relates to the current safety of the water and ventilation system. And where does your experience in risk and how it is managed come from?
So I've been in medical management for many years, probably about, well, coming up to 20 years, but not quite, in one way or another. I've spent 18 years as a director of infection prevention and control, where risk management is kind of the bread and butter of what you do in infection control, and certainly at that level where you're looking more strategically than operationally. I've held various clinical management roles where I've been I've led on the management of risk in pathology departments, in radiology departments, other clinical settings. Spent 5 years as a deputy medical director, where part of my role was around supporting risk management across the trust. And then for the last year and 8 months, I've been the chief medical officer at my trust, and I sit on the board and we manage board level risks. And I'm also co-chair of our patient safety oversight group, where again, we manage risk, and co-chair of our risk and regulation committee, again, which deals directly with risk and particularly in relation to regulation of clinical activities.
Well, first question is, are you willing to adopt this report as part of your evidence?
Yes.
Yes. What I want to do is to understand, firstly, I mean, you've quoted from other documents in this report. You've provided us charts from the Northern Ireland Infection Control Manual, from NHS England Principles of Assessing Risks, and you've referred to a number of documents, including the Orange Book. And I wondered, to what extent are the concepts in here specific to the health sector, or is risk management a rather wider concept?
Risk management is a much wider concept. I mean, every industry, every schools, every part of society has to manage risk. I think what is unique to the health sector is the patient safety aspect of it, and managing the risk around patient safety and taking the impact on patients when risk management, during your risk management, is really key to everything that we do in the health sector.
I wonder if we can look at the report and go to page 5. I hope I'm not being unfair, but paragraph 3, is that your original phrasing, or do you think is it something you've acquired from elsewhere?
I'm sure it's influenced from elsewhere, but it did come out of my brain rather than.
I mean, what's the influence of this idea?
I think safe, effective, person-centred care is one of those things that we. It's an idea and a concept across health. In relatively recent years, in those terms, it's something that we have to think about on a day-to-day basis. Patient first, patient at the centre of everything that we do. It's patient safety being absolutely paramount in the way that we run the hospitals, manage risk, manage everything that we do. So I think it's a very common concept within health, and it's something that is really important to maintain in all of the thinking around how we manage risk.
Has it always been the health sector in the UK? Has it always been, in modern terms, patient-centred, person-centred?
I mean, I've been around in health for 40 years or so, and I think it's theoretically yes, but I think the focus is very much shifted in during my career to overtly be around patient safety.
And what's, from your perspective, where do you think the pressure points have come to shift that focus? How's that shift in focus happened?
I think there's the realisation that over the years our thinking has evolved. Over the years we've become more aware of the importance of our patients. I think it's a very different from 40 years ago. It was you just tell the patient what you're doing and that's it, you're doing it. And now we would discuss with the patient, we'd make sure the patient was comfortable with the plan. We would take their thoughts and feelings into consideration. We would very much explain all of the potential risks, potential for something to go wrong in their care, what the side effects of their care might be. So it's very much a shift to better communication, better support for the patient, which has just evolved over many years.
Does that involve a different understanding of consent compared to, say, 40 years ago? Even though the legal test might not have changed, but the different practical understanding.
From a practical point of view, yes. I mean, the old adage that, doctor knows best and doctor will tell you what you're doing and, how he's going to manage your case, or even not, but just do it anyway, has very much changed to this very much patient-centred approach to care now.
And so how does that extend into the environment of a hospital?
So that means that the environment has to be as good as it can be to make it safe and comfortable for patients. I mean, I think a good example of it, leaving aside, is maternity care. So now you won't find a maternity unit that hasn't got a birthing pool, that hasn't got lots of bean bags and balls for birthing mothers to sit on, and they tend to be much more homely than clinical. We have birth centres which are very much like made into a more of a bedroom than a clinical setting to give birth, and I think that. So it's making a clinical setting more conducive for the correct care, but it's also thinking about the safety aspects and what could potentially harm the patient around the built environment that we place them into.
Yeah, I'm going to come back to safe probably after the coffee break in more detail. But at this stage, you've discussed comfortable there. I got them in the last few minutes, last few sentences. But what do you mean by safe? You've used it twice in that paragraph. What do you think safe means?
So safe is safe depends on the patient, to some extent, on the patient that you are dealing with. So
Sorry, I just missed that. Depends on
the patient that you are dealing with.
Right.
So some patients will be more vulnerable. So those who are immunosuppressed, those who are receiving chemotherapy, the patients at extremes of age will be more vulnerable than your average man in the street who is normally fit and healthy, and so on. And it's not just about the building, what it looks like. It's things like how safe the furniture is that you have in an environment. So can the patient trap a limb in the side of the bed, for example?
Can they fall out of bed?
Can they fall out of bed? Can they trap a limb? What's the risk of, if they do get out of bed, what's the risk of them then falling over, and what mitigation do you need to put in place to alert people if they get out of bed, and so on. So it very much depends on the patient themselves what will constitute safe. And so to that end, a patient in hospital, if we take, for example, an elderly patient, they would likely have a falls risk assessment to see what their risk of falling over would be, and whether or not, if they came out as having a falls risk, that they would put mitigation in place around that patient. They would have a nutrition risk assessment to make sure that their nutrition is good. They would have a pressure damage risk assessment. Do they have pressure damage now? Are they going to be bedbound for a while? What do we need to do to ensure that that patient does not develop a pressure area or a pressure sore, and so on. So there's multiple risk assessments that you would do for a patient to ensure that they are in a safe environment. An environment here, not just meaning the physical space, but also the care space, if you like.
Although we'll get into this in more detail, you see safe and risk to be connected.
Absolutely.
Right. Well, let's talk about that. We'll stay with risk for a moment and come back to safe. Paragraph 4, you describe the risk management process, and you seem to have 6 steps in it. Now, I wondered whether to some extent you got that's just your normal practice, or whether it comes from a particular place.
I think it's fairly standard. It's almost something that you don't think about because that's what we do. So if I think about my risk register, if we've identified a hazard or we identified an issue that could potentially cause harm, we would open a risk. The risk register then naturally pulls you through to what is the actual risk? What is the risk and how is that going to be manifested if it comes true? And then you do your risk assessment. What do you need to do in order to control the risk? And then once you've implemented your risk measures, what does that do then to the risk score? So you have a current risk score, you have an original risk score and you have a current risk score once you've implemented measures, or maybe before you've implemented the measures, your risk score will be the same as the initial risk score. But then when you review your risk every month, you will see that second current risk score going down. And then you'll have a target risk score, which is where you want to get to. And so the process is that's just what we do.
Now, I want to show you a document which you have referred to in here, which had a chart that I thought I might want to ask you about. But since it's the Orange book, you might not be comfortable about discussing this chart. And so let's look at it and see what you think when we get there. Because I haven't given you a notice about this. So it's Bundle 44, Volume 6, Document 11, and the document starts at page 128. And I want to first ask you about the Orange book and whether you've used it. You've referred to it, but to what extent would you use this as a source?
So it's not a day-to-day reference book by any means.
No.
It's a kind of overview. So it's there to refer to if you need it, but it's not something that you would use in daily
I wonder
practice
if we
if
go
your
to
processes are set up.
Page 150, Section D, Risk Management Processes, Main Principle. And there are lots of very exciting graphics in the Orange book, but this one seems the simplest. And I wondered if you come across this idea of a 4-part structure to the process of risk identification and assessment, risk treatment, risk monitoring, and risk reporting, and whether that bears any relationship to what you do in practice.
Well, it's not the process that I use on a day-to-day basis, but it does fit into what we do. And it says the same thing that I've just been talking about. It's you identify your risk, you assess your risk, your formal risk assessment. You would then put your mitigations in place. That's the risk treatment. So you would put your actions in place, and then you monitor the risk as you go and as your actions are implemented. And then you can, throughout that, you report and make sure that the governance structure around your risk is in place.
If we take that off the tree and go back to your reports, that's 44, Volume 6, page 5. The first step seems to be identifying hazards. And you define that as recognizing anything that causes harm, such as equipment, procedures, or environmental factors. To what extent does identifying a hazard involve acknowledging it exists formally?
You can't identify it as a hazard unless you recognise that it exists.
And
Because once you recognise it exists, you would then have to do some form of risk assessment, whether that's in your head or a formal written one, to identify it as a hazard rather than a.
so could you identify a risk in your head and decide it's not worth then considering anymore?
Yeah, it wouldn't be very good practice, but you could do it.
Now, you are operating at the scale of a trust.
Yeah.
And you have one hospital?
We have three.
Three, sorry, I wasn't paying attention. 3 hospitals. Now, I'm assuming your trust is not as big as Greater Glasgow and Clyde.
It's not.
No. Do you maintain a single record of your risks in the organisation or multiple ones?
So we have a single overarching risk register, but it's held on a database which enables you to pull out risks relevant at different levels. So our clinical services are divided into divisions. So 6 divisions. We can pull out all the risks related to one division to show that. And below that, we have directorates. We can pull out each directorate's risks. But it's one database, if you like.
But there will be directorate risks that don't get reported to the top level process.
Yeah.
And what is the sort of thought process that decides whether you consider a risk at the directorate level or the division level or the whole organisation level in your organisation?
So we have the governance structure, which looks at risk, and each of our divisions would bring their entire risk register, all of their risks, to that meeting for oversight. So it's an executive level meeting where we would we have the risk register there for that division. The division would identify, obviously you read the papers beforehand, but the division would bring forward any risks that they were concerned about, particularly red risks, and any concerns that the executives had that were not comfortable with, whether it was that they weren't comfortable with the mitigation or that they felt that it needed to be escalated, would then take that up to our non-executive level quality committee, which is a subcommittee of the board, for further examination. To the side of that, we also have at board level a red risk report, which is a review of all of our red risks, which we do at the board once every 3 months.
I want to go on to the next page of the report, page 6, where you discuss identification and mitigation. And you reproduced a chart from the Northern Ireland Regional Infection Prevention Control Manual. Now, I didn't reproduce it because I felt we've got one National Prevention and Control Manual. It might create confusion to have a second one in the papers. But what do you understand is being presented here in this triangular-shaped chart?
So this is the hierarchy of controls is something that we use, particularly in infection control, because it's a really neat way of expressing what you need to do to manage a risk. So it's an upside down triangle. So elimination is of the risk completely, just taking the risk away, is obviously the most effective way of reducing that risk. And it goes all the way down. You substitute it for something else. That's not always possible. That was quite an exciting subject in COVID. Engineering controls, how do we do that? How do we separate the risk or the hazard from the patients? The administrative controls, do we write a SOP? How do we change the way people work? Down to PPE, which is the least effective but is often where we end up.
So the first two involve, to some degree, getting rid of the risk.
Yeah.
Engineering controls is a physical change to the building system or whatever it is.
Yeah.
Administrative controls is telling people how to behave so they aren't impacted by the risk or less.
Yeah.
And the PPE is a barrier.
Yeah.
Right. If we look at over the bottom page, you started a paragraph in the context of the Queen Elizabeth Royal Hospital Children, built environment examples. It's not an exhaustive list, I appreciate, of mitigation according to the hierarchy of controls. And you've tried to see issues you know about in the inquiries references in terms of these elements. So your example of eliminations are, why would you have implementing of chlorine dioxide as an elimination risk?
It's a mitigation, not a risk.
Sorry, elimination. I'll that sentence again because I misspoke. Why would you have a chlorine dioxide dosing system as an example of a mitigation that eliminates a risk?
Because the idea of a chlorine dioxide dosing of a water system is to reduce the bacterial contamination of the water system. In its simplest terms.
Does that eliminate the risk then?
Potentially, it will eliminate some of the risk.
Right. And then you've put down the replacement of taps and hand wash basins in a ward as another example of elimination of risk. Is that the same? Is that the same idea? You're just removing that problem in its entirety.
Yeah, replacing it with something that is more effective. So the physical style and design of the wash hand basins changed, which made them less likely to splash, for example.
I did wonder why you had mobile HEPA filtration units in Ward 6A in elimination. How does filtering the air within the room with a filtration unit eliminate any risk?
Well, again, you're taking elimination as being complete.
So if they work, it's an elimination.
So it's a mitigation. It's not a solution. So none of these things are going to be 100% effective, but they mitigate some of the risk.
I just wonder why
methods of eliminating.
I can appreciate that replacing the tap, if the tap is the problem, eliminates a risk. What I'm having difficulty with is how mobile HEPA filtration units can eliminate a risk, and yet you've put installing HEPA filters, which actually filter the air as it comes into the room, as an engineering control. And I just wonder whether there's an overlap.
Yeah, because it is an engineering control. It's not an elimination control, if you like. It's probably a slightly moot point as to, where you would put it from that point of view. But it is basically an engineering control.
Because one of the questions that has arisen before is, if you have a risk and you take some step to mitigate it, and you don't completely eliminate it, you might well have successfully mitigated it, but the risk is still there. Or is that a reasonable way to understand it? We had a discussion on this, Dr. Ogwell.
So you decrease the risk.
But if you fully eliminate the risk, then the risk isn't there anymore. Now that was doing some work there. Could you expand on that?
So if you completely eliminate a risk, and I'm struggling because I can't really think of an example where you can absolutely 100% eliminate a risk. Risk management is all about mitigating a risk down to an acceptable level. Theoretically, you can reduce risk you can reduce risk down to a point where you say, we've done this, we've got this risk down to an acceptable level, we're comfortable with the level of the risk, we're going to close that risk. But there are other risks that you can mitigate down, but you say, actually, it's still a risk. And I'm not going to. So, for example, you could have the best rate in the country for healthcare associated infections, the mandatory, let's take C. diff. You could have the best rate in the country for C. diff, but still want to keep that on your risk register because it remains an issue, because there's always some part of that that you can't control, even though you're the best in the country. You'd want to keep that on your risk register as a relatively low risk.
So your understanding is that it's for the sort of risks that we are talking about in terms of water and ventilation systems. Your perspective on this is that elimination is very difficult.
Yeah.
Can you think of any of the things that we've discussed in this inquiry, given that I think you've read early drafts of Dr. Walker's report, where there is a absolute elimination that could or was done to one of these risks that you're aware of through the inquiry?
I think there's lots of ways where risk was created, but no, I don't think I can off the top of my head.
So just to put an example which was worth thinking about, you have a ventilation system as Forward 4B was originally built that was considered to be sufficiently risky that the patients went back to the Beatson. And then work is done and the patients return. You wouldn't see that as elimination of risk. It's a reduction by mitigation of that risk. It remains a risk.
Yeah, because I mean, there's a saying that nothing in health is 100%, so nothing in clinical medicine is 100%. There would still be a small residual risk to those patients.
And if you think about
just because they're so immunosuppressed.
You think of the example of the Arjo baths.
Yeah.
Which seemed important at the time they were fitted, but they no longer exist in the hospital. Is that a potential example of an elimination? You take away a piece of equipment that you're worried about.
Yes, because you remove the bath with its flexible hoses.
I mean, you might put a new one in that has its own risks, but that particular risk is eliminated.
Yeah.
If we move on to the concept of a risk register, you see benefits from using a risk register. Do you see any disadvantages from using a risk register?
No, it has to be a good thing to be aware of risk and to monitor risk. A risk register can give a false sense of security if it's not managed properly. So if someone puts something on a risk register and goes, there you go, I'll put it on the risk register, phew, that's okay then. That is not the way to manage a risk. That is writing something down and then pretending it's gone away. So it has to be managed.
You've described in paragraph 7 that risk should be proactively and responsibly added to a register, and an adverse event which identifies an unmitigated risk will trigger in addition to the register, but active risk management will also include horizon scanning and having regard to identify potential for risk to be realized. Does that come from anywhere, that concept of you should add things to a risk register, or is it just in sense practice?
It's just practice. It's just how things are done. And I mentioned horizon scanning and that can take many forms, but it includes things like you know, seeing what's coming around the corner. So predicting what the impact of the NHS 10-year plan, for example, is going to be, and adding a risk into your risk register if there is an adverse risk there. But you should be looking.
So, I mean, I'm not going to put it on the screen, but if there was an entry in the Greater Glasgow and Clyde Risk Register back in 2009 discussing the effect of a decision to move to single rooms, that would be an example of a horizon scanning entry in there, looking forward about something they know is coming but hasn't yet risen. Is that what you sort of mean?
Yeah.
And just for completeness, that's on page 9 of Bundle 45. But can they also arise internally within an organisation because you're aware that something's changing in your organisation and that creates risks?
Yes, absolutely. And it could be, changing a management structure, for example, could result in staff being unhappy, which could create people not being happy at work and then becoming inefficient and then productivity going down and so on. So it's that kind of thing as well.
Now, this section, which we're going to go through, reads a bit like some principles. So we turn to the next one. You've got every risk should have a, no, not next page, next number, 8. Every risk should have a risk owner at an appropriate level within the organisation. For organisation-wide risk, this should be executive level. When you say, well, firstly, is that practice, or have you got it from somewhere? Is it just the way that you see things being done?
That's just how you do it.
Right. For organisation-wide risks, I wonder what that means, because it occurs to me that you could mean one of two things. It could mean something like that risk I just mentioned, that if you're moving to single rooms, it'll affect across the organisation as they get rolled out. Or it could mean a risk that whilst it's localized to a particular division or directorate or sector, it's so insignificant that it'll affect the whole organisation if it eventuates. Do you mean both or only one?
So I think it is... So, for example, I'm the owner of our healthcare associated infection risk. So I own the risk of healthcare associated infections arising across the organisation. I also own the risk around resident doctors going on strike, both of which affect the organisation in different ways. The resident doctors going on strike is one that's realised, and the HCAI one is one that may or may not be realised. And we have controls in place to mitigate some of that, but for the resident doctor strike, the controls are around how we cope with it, not preventing them going on strike, if you see what I mean. So I think if you have a risk that affects the whole organisation, it should have a high level owner.
What about a risk? Well, firstly, is there any difference in your, in terms you're making some statements of principle here, and I'm inevitably about to ask you in due course to apply them to what you know about the Queen Elizabeth. And I just wondered before I do that whether there is a difference in the way one might discuss how a risk is managed once it's on a risk register and under process, and a view about whether it should be on a risk register at all, and thirdly, at which level it should be at. Are there any areas where you would be less willing to, not quite be adamant, but have strong views between those sort of different choices? Because it strikes me that the first choice is, do you put it on the risk register and do you mitigate it and go through the process? The second choice is, how do you put it through that process? And then subordinate to that is where in the organisation does the risk get managed? Those are three different issues you talked about. If I start asking you about particular risks, is there any consistency in the level of willingness you are to have an opinion? Because obviously you're talking about someone else's organisation. You can't have a full knowledge about their organisation. There are some areas where it's clearer than others. A bit like the way you wouldn't, if you criticise a fellow clinician,
Yeah.
your criticisms are different than if you, a judgment of a clinician is one thing, but to completely fail to spot a condition might be something else. Do you have a gradation, or am I asking a terribly unclear question?
Yeah, I'm not quite sure what the question is.
The question is there any difference in your eyes about whether you're entitled to have an opinion as an external viewer about whether something should be on a risk register at all, yes, no, compared to how is it managed once it's there? Do you feel that as an external viewer you should have a different level of opinion on those things?
I think I can have an opinion on what my expectation might be for a similar event happening that in my organisation. I can have I think it's an opinion rather than a criticism.
Understand. So to go back to this question in 8 about appropriate levels, before I ask you a question, I want to understand some theoretical concepts before I phrase the question. Imagine, I'm sure you do, you have within your hospital services that use a particular piece of equipment. And there will no doubt be risks arising from that piece of equipment. And you're nodding, remember the transcript person. Now, if you've got a piece of equipment in a service that's in one division of your hospital, one directorate, what are the principles that decide whether it ends up on just the risk registers for that small part of the organisation, or it makes it up to the top level of the organisation? How would you discuss such a theoretical example?
So if you had a piece of equipment, say you had a CT scanner which was coming to the end of its life, or had exceeded the end of its life and was, in need of replacement, but there was no money and it couldn't be replaced, for example. That would be a risk which was, and it kept breaking down. So your risk is growing because it's unstable and therefore you're increasing the risk. So that would be a risk which was particular to that directorate, particular to that division, because they would carry that risk. But when it got to the point that it was a red risk in that, patients' scans were being delayed, patients' treatments were being delayed, so it was having an adverse effect on patients, and in some places possibly a severe delay affecting patients, and it was certain to happen, then that would elevate the risk score to 15, 16. And in that situation, I would expect that to be reviewed at board level.
So something can be localised until it becomes much more likely to happen and its consequences are more severe.
Yeah.
Right. You've mentioned in 9 that risk management is a dynamic process of reviewing risk, assessing effectiveness of mitigation, and assessing the risk score in light of improvements, and then implementing actions may mitigate both the likelihood and consequence of risk. And you discussed, you produced with a risk matrix here. And that's where I think 15 is, which is given evidence, comes from. In that it's
actually, my calculation was wrong. It'd probably be a 20.
A 20, so it's when it goes red. And how do you get to those calculations? Is it a multiplication exercise?
It is, yeah.
So
So you
if
go
you score-
down and cross. And
so if you say
figure
that
out.
something's a minor risk that's possible, it's 2 times 3 equals 6.
Yeah.
And a minimal risk that's almost certain but it becomes a 5.
Yeah.
Right. Now, 10, risk scores are pertinent to the level of safety or unsafety which can be identified. For example, a risk was almost certain to be realized, but the consequences of minimal or minor would not result in unsafe environment. A risk that was almost certain to be realized, but the consequences of severe or even fatal, if unmitigated, would result in an unsafe environment. So, is it your position that there's a connection? The connection between risk and safety is about consequences and likelihood?
Yeah. Because you have to be able to measure it somehow.
Now,
and doing that risk assessment would draw you to a measurement.
We asked you and your colleagues a series of questions in the inquiry. And key questions 1 to 3 all used a variation on the idea that unsafe was defined as an avoidable level of risk. Are you happy with that definition in our questions?
Well, if you translate that into a risk matrix, just using the word avoidable alone is not enough to be able to determine safety or unsafety.
So our question might have effectively only used the 1/2 of the calculation, as it were.
Yeah.
We've just considered the prospect of it being realized.
Yes, whereas you need to think about the consequence to the patients of it being realised.
Well, we'll come back to that at the end of your evidence this afternoon, Lord.
Right, sorry, and it was just, I'm not sure that I heard the full part of Dr. Mumford's answer. I think I got the step of having to have regard to likelihood of occurrence.
Yeah.
What did you say after that?
And the consequence
And
of that
consequence,
happening.
right.
Now, before we go and look at some risks, as it were, let's continue proceeding through your report. You've discussed in paragraph 11 the idea of a risk appetite and the concept of tolerance. What do you mean by that?
So risk appetite and tolerance are how risk averse or otherwise an organisation is. So, and different risks will possibly carry different risk tolerances. So, for example, if you have a patient safety risk, your risk tolerance is going to be really quite low if a patient can come to serious harm as a result of that risk being realised. If I've given the example of a financial risk, the tolerance of that might be much higher, and you might be comfortable with a higher target score for your risk. So we talked about target scores being in the risk register.
And this is the scores in that scale of 1 to 25.
Yeah. So you might feel that if you had a financial risk with a moderate consequence, and it was possible, then that score is 9. That's a kind of medium risk. You might be comfortable with that for a financial risk. But actually, would you be comfortable if the consequence for the patient was moderate harm, and that was still possible that would happen? You possibly wouldn't, and you might prefer to mitigate that down and say, actually, I want that to be unlikely to happen.
To what extent does this concept of risk appetite or toleration actually involve not so much what the numerical score is, but understanding the two elements within it. So if you look on the chart above, there are 2 points that score 8 and 1 point that score 9. They're not actually the same because they involve different levels of consequence and likelihood. So to what extent does a understanding of a toleration of risk or a risk appetite involve thinking about more than the simple numerical score? It's about what's our tolerance of consequence and what's our tolerance of likelihood.
Yeah.
How does this idea of tolerance or risk appetite link, going back to the discussion we had before about patient-centered care and modern ideas of openness and informing patients and consent in the modern sense?
How does risks or link back?
Yeah, so I mean, to what extent does an organization's tolerance of risk have to take account of the patient's tolerance of risk?
Yeah, so I think there will be occasions when having a particular surgery, for example, for a patient will present a risk to that patient. It won't present necessarily a risk to the organisation, but it will present a risk to that patient. And then the patient will have to, you might say to them, you've got a 10% chance of, say if you were having a thyroid operation, and I don't know the actual numbers for this happening, but thyroid operation, you can cut one of the nerves to the larynx and change people's voices. So suppose you said to a patient, there's a 10% chance that during this surgery, because we've got a slightly incompetent surgeon doing it, your nerve will be cut and you might lose your voice. And the patient might say, oh, actually, I'm not willing to take that risk. On the other hand, you put your top surgeon on the job and the top surgeon says, well, actually, there's a 1% chance in my hands. Like the last 100 patients that I've done this surgery on, only one of them has lost their voice. So the patients may say, well, actually, I'm comfortable with that because that's 99% chance that I'm going to be absolutely fine. And they might be much more comfortable with that and say, I'll have the good surgeon than the trainee in that circumstance.
What about the sort of building risks we're talking about here? So I don't want to get into a specific one, but you can imagine a theoretical imaginary risk that involves, there is a feature of the building that gives rise to a risk. And that risk might have a low likelihood of happening and a medium consequence if it does. And the organization might have a particular attitude to that risk and tolerance. What about the ability of the patient or patients who are being treated in that space? Where do they get an input into their tolerance of that risk?
So I think that's quite a tricky question because the likelihood is that they wouldn't, because that risk would have been accepted by the organisation. What you described would be a kind of medium 6 risk, and it's unlikely that would be disclosed to the patients.
At what point do the risks of these sort, the physical environment risks, I mean, where on that figure 2 matrix do we have to get to before you have to start, in your view, disclosing it to the patients? Again, I'm not talking about any specific example, but just in terms of...
I think it varies. So, for example, we have a process. If we have a COVID patient, for example, who we discover in a 6-bedded bay, so all of those other patients have been exposed to COVID, and it's nothing. There's nothing you can do to prevent it. The patient didn't have COVID when they came in or wasn't showing any symptoms, but the day after they were admitted, they developed COVID symptoms and we did a test and they were positive. So we tell all those other patients, but then we move that patient out into a side room to protect the other patients from further coming into contact with COVID. However, they've all spent the night in that 6-bedded bay with the patient. So one of them may develop COVID in the next 5 days. On the other hand, we've got an empty bed and we have no beds and we have 20 patients in A&E waiting for a bed. So we say to the patients who are waiting in, we risk assess them, as in, are they very old and frail elderly? Have they got any underlying disorders which would make them particularly likely to develop infection? Are they immunosuppressed? Are they on steroids for whatever reason? And then we look at the other patients and we will say to them, we can pop you into a bed now on a ward, but it's in a bay where a patient has previously had COVID and the other patients in there have been in contact with that patient and so may develop COVID in the next few days. Are you willing to take that risk? Now that's an example of where, you know, the risk is, the consequence is probably moderate because COVID is not, in a genuinely healthy person, is not severe in most people anymore. But it's a fairly high likelihood that they will be further exposed to another patient who becomes symptomatic with COVID. So therefore, you've got a score of 12, and that's partly around making patients, giving them the information that they need to be able to assess whether they want to take that risk. But it's also a known risk that we would be subjecting that patient to and that we have to disclose to the patient because we know that that is a likely thing to happen.
Just because you've described this in some detail, do they generally accept the risk?
Not often, no.
No, right. And I think you discussed in paragraph 12 that risk tolerance can be identified, further refines different cohorts of patients. And so I think we're familiar with that, so we'll go over the page. And then the discussion of the regular review of risk registers. Now, before we get onto that, you discussed the idea of an organisation's attitude to risk and its tolerance. Can an organisation be said to have tolerated the risk it has not identified or put on its risk register?
Those two are two different things. So is there a risk that they haven't identified? And nobody in the organisation knows that that risk exists. There's really, should they have identified it? It's a good question to ask. Could it be reasonably be expected that they would have identified it? But if it's absolutely, you cannot expect anyone to have recognised this risk happens, then you're not tolerating it, you just don't know about it.
But if there have been meetings or email communications or SBARs or anything like this about a particular risk, and it doesn't make its way onto a risk register, is it appropriate to describe the organisation as tolerating the risk, or is that to mix two concepts?
Depends what level of the organisation you are saying is tolerating that risk. If it's been escalated through a governance process, then it still hasn't been recognised and put onto the risk register, then you can say, yes, they are tolerating that risk in a kind of,
But not in a risk registry sort of tolerating it.
But not in a kind of risk registry sort of a way. But if it has stopped at a low level and no one has escalated it and no one at that level has recognised the significance of it and either escalated it or put it on the risk register themselves, because anybody in an organisation can discuss a risk and potentially put it onto the risk register, then that's something different. So
That's not risk register toleration, that's something else.
yeah, that's because if it stops at a fairly low level in the organisation, so that the structure of the organisation is not aware of it, then the organisation as an entity cannot be said to be tolerating that risk.
So there seem to be multiple factors here. There's the who knows about it, what did they do about it in terms of escalating it or putting it on the risk register, but it's only once it's on a risk register that it falls into this category that you discussed, I think,
No, because
of being a the organisation actually choosing to tolerate it.
So with one caveat there, so it could have gone up through the governance structure.
Yes.
And nobody recognised the significance of it, and therefore it not reaching the risk register. Because the risk register doesn't just happen.
No.
Somebody has to say, which we do on a very regular basis. Someone will talk to us about something that's happening, and we'll go, "Have you put that on the risk register?"
So you might.
If you haven't, you should.
If you take an example, a hypothetical example, you have someone writes a report that identifies a risk, and so one place it could stop is that the person who reads the report just doesn't escalate any further. And then you can't say the organisation is tolerating this because the organisation doesn't know. The next stage is you might have a conversation of should the organisation know, but it actually doesn't. And you're nodding again.
Sorry, yes.
The next stage is that it does leave that individual lower level person who knows about the report, and it goes up in the organisation. And either it gets onto the risk register, or a person either doesn't put it on the risk register because they chose not to, or just doesn't think about it.
Yes.
And to what extent at that stage could you be saying the organisation is tolerating the risk?
I think you potentially could. And it could be that actually, even though something is escalated, it's not recognised for the risk that it is.
So you might get a lower level person saying, I'm worried about X.
Yeah.
And then it goes up to a more senior person who reads that message and goes, well, you might be, but I'm not for these reasons. And that could well be the organisation tolerating the risk because that person's senior enough to, in a sense, speak for the organisation.
Potentially.
Potentially, yeah. Right. Paragraph 14. So you've got, paragraph 13, review. When you say board level, in your organisation, because I think we have to put your view, your experience in context, you mentioned a non-exec committee who are looking at risk registers. So can you describe them a little bit more clearly?
So we have a series of board subcommittees which are chaired by non-executive directors who sit on the board.
Yes.
They chair these board subcommittees, which kind of filters some of the, so it raises information up to board level non-executives and executives, and then a escalation report goes to the board rather than all of the information to all of these committees.
So these board subcommittees are effectively hearing about things independently or from rather than through the executive board members.
Yeah.
And is there one that reviews your risk register?
Yes, quality committee.
Now, the papers of that committee, they will report up to the board.
Yes.
And do they report regularly on risk or exceptions, or what's the sort of standard that gets into a board report?
So at that level, it will usually be exception reporting from the quality committee, but then next to that is a review of red risks, which goes separately to the board every 3 months.
But that review is coming out of the executive side, the red risk review.
Yes.
Right. In terms of your public accountability outside the board, I'm assuming your board papers eventually end up on your website and are publicly available.
The public boards do, yeah.
Subject to commercially confidentiality and confidentiality.
Yes.
This non-executive committee that deals with risk reports, do those papers end up on externally to the organisation, or they just stay within the organisation?
No, they stay within the organisation. I think they are FOIable, but
The reason I ask that is because in terms of the public accountability of your organisation, how does the risk register make its way onto the main board and therefore into the generally public domain reporting? Which bits of it? Is it just the exceptions? Is it just the red risk? What do you put in your public spaces?
it will be the exceptions. I'm trying to remember which part of the board the risk register goes to. I can't remember.
The reason I asked, and maybe the answer will be sufficient, is could it be that most of this process that you've described in your organisation remains below the level of the public reporting minutes? So, for example, I can't go and look on your website and discover that you've got a red risk over a CAT scan in one of your directorates.
Only if it went up through the quality committee papers, because the papers for the board are publicly available.
Right, so the papers of the quality committee end up on the board papers as an attachment. Right. And so the discussions of organisational level risks ends up in your board papers and ends up being public, subject to the normal confidentiality commercial sections. Right. Now, what are you saying at 14?
So systems thinking is the concept of when you're looking at a risk, you don't just think about the risk in the finite areas. So if we go back to the CT scanner, for example, you would think about how that impacts across the organisation or even outside the organisation. So you may think about how does it impact on patients? What does that do to, for instance, your cancer standards and your cancer diagnostic standards? How does that impact on GPs if your CT scanning capacity goes down? So what is the wider impact in the patient population? How does that impact on outpatient clinics and follow-up of patients and the timing of follow-up of patients and so on? So you would think much more widely rather than just thinking about that CT scanner. And you can use the same sort of thinking about when you're making a change which may impact. So if you're making a change, you need to think not just about where that change actually happens, but the ripple effect of that change on other parts.
And then in 15, the concept of the residual risk, do we return back to risk appetite and toleration again? That you have to end up with a residual risk that stays within your toleration threshold?
Yes.
Now, what do you mean by oversight of risk within an organisation is vital to ensure safety?
So this is what we've talked about in the governance process.
Right.
And how risk is viewed, and making sure that the person who is holding that risk, or the person who's holding the risk, is doing everything, and that the risk is moving forwards. So sometimes you'll find a risk that just sits at a 20, stays at a 20, stays at a 20, and actually you need challenge, which is where the oversight comes in, to go into that to say, actually, you're not having an impact on this. We've reviewed it, and none of your actions are actually having the impact that you would want to, in order to reduce this risk down to the target level.
But you can only do oversight if the risk is on the register in the first place.
Yeah.
And in 17, you describe what a risk appetite is and the benefits of using it. I wondered if you could perhaps give an example, maybe a reference to this unfortunate CAT scanner, of how you would think through the process of accepting a risk. So if you're going to accept the risk of the CAT scanner for some reason, maybe because you don't have the money to replace it, what's the framework you would apply to that sort of decision process?
So you would have to look at the impact. You'd have to be comfortable that all mitigation that you could possibly put in place had been put in place. You'd have to look at the impact of that, and what the prospect for buying a new scanner in the future actually look like, in order to say, so we haven't got any money this year, but next year it will be the number one priority on our capital programme, for example. So you may say, we can't do anything about it just now, but in 9 months' time, we will have the money, and we will make sure that that's the first.
So you can time limit the risk. You can say, because I know I'm going to make it top priority.
Yeah, so you would tolerate it for a set period of time.
What I want to do now, I think, is to move on to the section you've called risk and safety on the next page, page 10. What I felt it was important to do was to just take you through this section. Then we'll have, after the coffee break, a more structured discussion about particular risks. You're effectively raising two ways that you can see a risk, identify a risk. You identify a risk because something has happened and you think it might happen again, or you identify a risk because it hasn't happened yet, but you noticed it.
Yeah.
Yeah. And you have the final sentence: the response to the risk in terms of recognition, acceptance, and mitigation, together with the risk management and governance, are key to determine the level of safety. Now, at one level, that sentence seems to wrap up the entire paper in a single sentence. But can you expand on that by explaining how the response to a risk, its acceptance, recognition, acceptance, and mitigation, might turn something that previously had been thought to be safe to something is unsafe? Or am I answering the wrong question?
Is that the wrong way around? That you're trying to turn something which you've recognised as potentially unsafe into something safe?
So if you have something that is unsafe, how is it that recognition, acceptance, and mitigation can turn it into safe?
So recognising it is part of the challenge. You accept that there is a risk, and then you put your mitigation in place. The mitigation, as we discussed, needs to be something that will reduce the risk level. So where it can't necessarily reduce the consequence if that risk is realised. So the impact on a patient would still be the same, whether if it happened. But what you can do is alter the likelihood. So you alter the likelihood of it happening by your mitigation, and you drive down the risk score to the level which you accept or tolerate that risk.
And that might well, at least it should do, push you below the unsafe threshold that you have in your mind.
It has to.
Right.
Now, and that level may change depending on your patient population, that where the risk is, but it has to push it down into safe.
Now, just to look at, say, in terms of your own chart, if we go back to page 8, is it possible, or is it the wrong question, to look at that chart and say there are some of those 25 squares where you are considering something to be unsafe, and some of those squares where you're considering it to be effectively safe? Or am I asking the wrong question in this context?
I would say it depends.
Depends, right?
But clearly, something that is going to have a major consequence or be severe and is almost certain to happen, definitely unsafe.
Yes.
Something that's likely to happen that's going to have a major or severe consequence, also unsafe. If you go to the other end of the spectrum, something that is rare and therefore extremely unlikely to happen, but we know it would have a severe consequence. If you've put all of the mitigation in place that is possible, then you may have to accept that risk, even if it's in a particularly vulnerable patient.
What I wanted to ask about now was the idea of how you assess these two requirements, these two thresholds, because consequence might be easier to assess, because if a risk eventuates, the patient will suffer consequence X, and you're a hospital, so you're quite good at assessing what consequence X means for people.
Mm-hmm.
And so is it ever difficult working out what the consequence is and how serious that is?
Yes, it's even when something has happened and you've examined something and investigated what happened, it is still sometimes difficult to put a measure onto the harm that has been caused. So there are difficulties.
I mean, it'd be helpful to get some examples around that, because it sounds quite a complicated idea. If we take some examples of, let's imagine the one we were dealing with, which is those environmental infections that we discussed that started everybody's evidence with. You might have a question of what's the consequence of getting one of those infections.
Mm-hmm. I think that would probably possibly be easier to
an easier one
to assess.
What about the airborne infections we've been talking about, the aspergilluses, the cryptococcuses? Is that one where you might find it harder to work out what the consequence is?
Well, only from the point of view of the patient population. So we know.
I'm ignoring likelihood. I want to come back to that. But thinking of the patient who got the thing you were trying to avoid them getting. You've explained, and I think we understand that for a certain group of patients, getting the environmental infections is bad. Everyone seems to understand that. But
so there's obviously a spectrum of consequence, isn't there? So if you acquire Aspergillus infection, you've got anything from a moderate consequence, say, which keeps you in hospital for a week, right up to a severe consequence, which may have a fatal outcome. So you would have a range of consequences, and that would then play back into the individual patients
And that would play
and their
into
vulnerabilities.
that would play into assessment of consequences.
Yeah.
Now, I do appreciate there are more harmful consequences than simply waterborne and airborne infections, but in this inquiry, that seems to probably cover it. But if we look at likelihood, how easy is it to assess likelihood when you're looking at a risk register? And what do you do when you just don't know? If you think about it, think of the difficulties you and Dr. Agrawal have had over what is the likelihood of catching aspergillus in a pediatric oncology population. You two don't agree. We haven't gone over in great detail, but it's fair to say you don't agree. How do you assess likelihood in that sort of environment?
So that's quite challenging, and would require you to do a really comprehensive risk assessment. I think it would hinge around whether, I mean, so you're opening, so when you open the risk, so your initial score, let's take. So things like, is the ventilation to regulation would be a really important question. Is there building work in the vicinity would be another really important question to ask. They would impact on the likelihood of you acquiring aspergillus in those situations.
What do you do about the fact that it does seem in this inquiry that there isn't an awful lot of direct evidence about the impact, particularly of air change rates, on the likelihood of acquiring airborne infections? Because we had Professor Humphreys at the very beginning, discussion of that work. Is it Lilly doing the works of operations here in the 70s? We've had evidence from Dr. Agrawal, Mr. Poplar, Mr. Bennett. I'm going to forget people, but we've had lots of evidence from both sides of the divide. And it does seem, and perhaps even Dr. Drumright and Mr. Mukherjee have agreed, there's not a statistical significance in the aspergillus signal for the pediatric patients that they looked at. How does a simple, almost ignorant lack of knowledge about the chance of harm happening, how does that feed into a risk register?
So that's absolutely bread and butter for a risk register. It's the risk of something occurring. So if on day one of the hospital opening, it had been recognised that the ventilation was not HEPA filtered, that the ceiling tiles were not sealed, that the rooms were not positive pressure, and that there were there were thermal wheels present, and that there were chill beams, and all of the rest of the issues around the ventilation in the Schiehallion unit. If on day one of the hospital opening that had been recognised, then the theoretical risk, you don't need to have realised the risk, as in it hasn't had to come true to assess that. But you would say this ventilation system has not been built to regulation specification,
Guidance,
or
not
to
regulation.
to the SHA
Guidance, not regulation.
Sorry, guidance. Not been built to guidance. The guidance is there in an evidence-based. It's been constructed in an evidence-based manner, based on fairly old research, but good research nevertheless, around what ventilation needs to look like. And it's there for a reason. It's there to prevent harm. So in that situation, you would say, this is a really high risk to our patients.
But why would you say that on this two-axis chart?
Because the consequence potentially for a hem-onc child could have a fatal outcome, and therefore it has to be severe. So you're already in the top row of the
Can we
chart.
put the chart back on the screen, please?
And if you then look at, is it possible? Is it likely? Is it almost certain? Or even is it unlikely? Well, it's not really unlikely anymore, because you've built a ventilation system which is not to the guidance, unless you believe the guidance is not worth it.
But that's my point, is that there is an argument that it is.
But it's generally accepted as being the standard to which we want to attain in building a new building.
Because if we...
So then you look at, is it possible? Yes, it's possible. Is it likely? Well, actually, there's a lot of building work going on the site, and which would play in, because you've got a unfiltered ventilation, so unfiltered air intake coming into the room, which is not positively pressured, which will also take in air from other sources when the door's opened. So is it likely, or is it almost certain? Well, it still remains rare, or unusual, should we say. So it's not almost certain, but probably you would stick at likely. So you'd have a 20 risk.
So if we just
didn't know any of what we know.
If you so there is a countervailing view, as you know, but there's no evidential basis for. I'm looking at this in the context of non-specialist ventilation spaces, but there's no evidential basis for air change rates in general. So if we take that discussion you just had and we transfer it just before the coffee break to a general ward. So now, presumably, the consequences are less serious. You're nodding.
Yes, sorry, yes.
And so that pulls it down the scores, because we now move from being, how did you have it before the consequences were severe? It moves them down into the lower levels of that chart.
Yes.
But I'm just wondering, it doesn't matter whether the same issue applies, presumably, whether it's the non-filtered spaces in Ward 2A with the vulnerable patients, or the non-filtered spaces in the general wards. The question is, what is the impact on your assessment of a lack of knowledge of the likelihood? Because what we're being told is that air change rates, HEPA filtration, the guidance isn't evidence-based. We should not think of it as it's out of date. It doesn't have real validity anymore. How does that debate find its way into this risk matrix?
I think when the SHTM and the HTMs were first written, they were written with good evidence around operating theatre ventilation, which was extrapolated out, because now that we have generally relatively low infection rates in these areas, you can't repeat the experiments that were done at the time, which makes the evidence base really challenging. However, what we do know is that we know the rates of, or we know the incidence of Aspergillus infection to some extent in different patient groups. It's unusual to find it in patients unless they have chronic lung conditions or are immunosuppressed or are severely immunosuppressed, like the hem-onc patients. And we know that there's a lot of Aspergillus about, so we know that most people are exposed to it at some point in their lives and don't develop infection. But we do know that certain situations, patients do develop it, and it has been linked in the past with things like building work. So whilst it's very easy to say the HTMs, the SHTM, it's not evidence-based, but we don't have anything better. And we have to have something that our buildings are built against in order to protect our patients. And it's been picked up across the board. The JC
it doesn't require HEPA filtration.
It doesn't require HEPA filtration, but it does require other parts of ventilation. But we know that, having building work in the same locality as patients who are very immunosuppressed adds an additional risk. And we spend quite a lot of time prophylaxing our patients against that additional risk. If we have things which we think are going to mitigate that risk, including HEPA filtration, why would you not?
No, I do appreciate that, but just to stay with the likelihood line,
Yeah.
I get the impression you're not saying, well, where are you would put this, and I know it's only your opinion, and I'm using it as a thought experiment rather than relying on your opinion on how to manage hem-onc patients, but you would put it up at likely or possible. I think somebody else might say, there's not an evidence base, I'll put it down at rare.
But actually, as long as you having that recognised as a risk on your risk register and doing something about it is the key thing. The recognition, the doing something about it. Being picky about whether you make it a 15 or a 20 is not the most important thing. It's how you mitigate it and what your risk tolerance is and how you reduce it.
Thank you. Well, this might be a good point to break for coffee.
Well, we'll take our coffee break, Dr. Mumford, and try and be back for 5 to 4. Thank you. Could I remind people in the room that conversation can distract the witness and therefore perhaps should be minimized? No, Mr. Mangendorf?
Thank you. Dr. Mumford, I wonder if I could return to one thing in your report, which I think I glossed over, didn't give you the opportunity to talk about, which is on page 5 of Bundle 44, Volume 6. Page 5, paragraph 4.1. There we are, yes. So you had a 6-stage process, and the first stage you had to identify hazards. And I wonder if you could explain, perhaps, in a sense, what's the difference between a hazard and a risk?
So a hazard causes a risk.
So can something be considered about whether it is a hazard, and then one decides it's not a hazard?
So a hazard is, so as a hazard is anything that can cause harm. It doesn't have to be, it doesn't have to be a bucket on the floor that people can trip over. It is, it can be faulty equipment. It can be something, the way that we're doing something. It can be something environmental. And then that translates into, so we've seen this, does it present a risk to our patients, to our organisation, to our staff, whatever?
Is there possibly in some ways a little read across between a hazard in this context and our potentially deficient features? It's a thing that
Yes, and it can be
could
an
cause harm.
and it can be an absence of a thing which produces a hazard.
And equally it can be a process. So,
Yes.
for example, a dysfunctional team, that could be a hazard.
Potentially, yeah.
Right. What I wanted to do was to then look at a group of hazards or potentially deficient features or issues that we have looked at. And there's quite a long list. Now, obviously, I'm conscious that you're familiar with all these because you've discussed them in your reports. You've reviewed reports by Dr. Walker, Mr. Bennett, Mr. Poplet. You've reviewed reports by and statements by other people. You've read contemporary documents like the DMA Canyon report or the Innovative Design Solutions report or Mr. Leeper's report. So what I'm hoping is as we go along, we can have a conversation about each of these things. I'll try and summarize them. And please, if you think I've mis-summarized, tell me. And equally, I would point out to those watching that I'm just summarizing them. So I can't give a full definition of a particular deficient feature because we probably haven't got time. So in some cases, I'll use a shorthand. And I'm hoping that you will know what I'm talking about as an issue. And so we can have a conversation about topics without spending an exhaustive amount of time fully defining every single topic.
Right.
But you shouldn't hesitate to pull me up if you think my definition is flawed or you don't understand it or you think I missed something of significance. Because you've had the opportunity to look, and I emphasize look, at Bundle 45, the GGC risk register. And presumably you haven't read the whole thing.
Not cover to cover, no.
No, I mean, it's about 800 pages, the PDF. And don't worry, I'm not about to put it on the screen. And we had to redact it because most of the risks that NHS GGC properly manage have nothing to do with the remit of this inquiry. And therefore, most of that PDF is black because we redacted out the content. but I know you've looked at parts of it. And so what I'm going to do is we may look at a couple of pages on the way past and discuss them. So what I wanted to do to start off with is the idea that risks might arise from the very process of building a hospital. Have you been involved in procuring a new unit or a new ward or a new extension or a new hospital?
So when I first came into post as Dipsy at Maidstone Tunbridge Wells, that we had a new hospital under construction.
Right. So I wonder if one can think about the sort of hazards that or sort of issues we know have arisen in this context. So we know, for example, that was a decision made to build the single rooms in the hospital with an air change rate of 2.5 to 3 air changes now, 40 litres a second. Now, you're familiar with that decision. Remember, you can't just nod.
Sorry, yes, I am.
I wonder if you could help me about how you would think about this in the context of risk management and the extent to which you would anticipate this would make its way onto a corporate as opposed to a project or departmental or sector risk register in order to be managed, if it needs to be managed.
So every big project like that, when even just building a new ward or let alone a new hospital has a big project risk register which addresses all of the issues. And in my experience, there is a governance purely around that big project, which is a project board, which has executive representation on it. I think from the risk point of view, for a risk to be escalated off that project board, off that project risk register and onto a trust risk register, it would have to be really quite significant. Although there are some things, like one example I can think of is that we had a risk on our trust risk register related to moving the patients into the new hospital, which wasn't on the project risk register, that was on the trust risk register.
And when you say really quite significant, is this scores in the 1520s territory that you're having in mind, or are we thinking about something else?
Yeah, and I think it would be more that it would have, that the impact would be felt organisationally as well as in the defined project. So
you would have to have an impact outside the project across the organisation?
Yes.
And this is, and if you think about the other two, or the other three issues that we have come across that I want to ask you about. So I'm going to put these three to you and then we'll come back to that question again. So there's the use of chilled beams in many rooms and wards. There's the pre-filling of the water system 18 months before handover, and the decision to go ahead and use Horn Optitherm taps after the meeting with HPS in June 2014. Now, thinking about that question of should those issues get out of the project risk register to a corporate level, how would you see the debate, if there is one, about whether they should, those four or any of them?
I think probably during the construction and up to the point of handover, which isn't, of course, the same as opening the hospital, that they would stay on the project risk register. And then at the point of handover, they would probably be, if they were still on the risk register for the project, then they may transfer over into the main risk register.
I suppose that's not quite an answer, but if you look at the corporate risk register in this case, the Greater Glasgow and Clyde Health Board, they just acquired a new hospital. At this stage, these 4 things have happened. Do you feel strongly or not about whether they should have been on the corporate risk register after handover? That is, the air change rate derogation decision, the use of chill beams, the fact that the water system being pre-filled, and the use of whole oxygen taps across the hospital.
I think for 3 out of the 4, I would say yes.
So what's the one you wouldn't say?
The chilled beams.
And why is that?
Because at the point of construction and handover, the SHTM guidance didn't have the same caveats in it around chill beams as it does now. Because now it has the information that they shouldn't be used or they should be thought about really carefully if you want to use them in healthcare, and that they have to have separate agreement from a ventilation group. And I think that wouldn't necessarily have been recognised as the risk that perhaps from the evidence presented to the inquiry that we now think it is.
So if we put that one to one side and go back to the air change ventilation derogation, what are the issues around why that should be on a corporate risk register at that point, if you have a strong view?
I think it should. I think it presents a risk to some populations of patients.
Why do you say that? Because we have, for example, if you think back to the chief executive of the construction company, he was very clear that he understood it. I mean, he's not a technical expert, but very clear that there's a position to be advanced, that it doesn't pose a risk to general patients.
And that may be the case, and that's why I said general populations,
right?
Because I think it's very, very difficult to measure whether or not it has been a risk to the general population of patients. But for certain populations, I remember that there was no, perhaps a more specific risk might have been that was implemented across the entire hospital without change for use of wards. So
places like Ward 2A and
2A, 2B, 4B, ITU, 4C, yes.
Yeah.
So that derogation was used across the whole hospital rather than following the guidance which specified different levels of air change for different areas and ensuring that that was followed. So that would probably be the risk that you would want to have rather than
the specialist part, as it were.
Yes, rather than the derogation as a whole.
What about the point that it seems, we haven't heard from all the witnesses yet, but it seems quite possible that out with the project team, there wasn't an awareness of the existence of this derogation. So how does that affect the discussion we previously had about how can you put something on the risk register if the organisation corporately doesn't know about it?
So, and it may not have been recognised as a risk even in the project. I don't know. Because if you did have an executive-led project board, you would expect that if it had been on the risk, if it had been on the risk register, that would have been a subject of some discussion at that project board, or if the derogations had individually gone to the project board, or however the governance was run. But if it wasn't recognised as a risk by the project, then it wouldn't have been escalated.
And then it wouldn't have made its way on the corporate
Yeah.
register. If we look at the pre-filling of the water system, if that's one of those ones you think should be on register, do you have a strong view about it, and on what basis should it be on the corporate register?
But as you know, I'm no water expert, but 18 months in advance of use does seem like an awfully long time just to the untrained eye.
We're going to get Mr. Poplar's view on this. Maybe we'll come back to that when we talk about the water system as a whole. The Horn-Optitherm taps, given the terms of the meeting, I wonder if we can put the minute on the agenda, or the minute of the meeting on the screen. So it's bundle 15, document 9, page 692. It is not on the document list, and I'm grateful to my colleague for hunting it down. Oh, it is fantastic. So this 5th of June 2014, it's a meeting at the South Glasgow Hospital, chaired by Mr. Stewart from HFS, with representatives from the Health Board, Health Protection Scotland, and including Dr. Walker. If we look at we go on 2 pages, and we look at the actions, and look at 5.3. Stop me if you think I'm going too far away from your expertise. But the last sentence, there was no need to apply additional flow control facilities or remove flow straighteners, and any residual or perceived or potential risk would form part of routine management processes. Do you have a view about whether those residual, perceived or potential risks should have made their way onto a risk register?
I like to think that I would have if I'd come across that in the build of my hospital, I would have put that on the risk register.
When you say you like to think, you're not necessarily sure people would do.
No, I like to think that I would.
Right.
I think there is a lot about it, isn't there? There's the risk that the routine management process would not be done properly. That's a risk. Maybe that should be on the risk register. I think with the benefit of retrospection, you can say, well, that was a mistake. At the time, they had all of these experts in the room, and they made what is quoted as a unanimous agreement that they would stick with what they had. I know that Dr. Walker's view of that meeting is slightly different, and that he didn't feel that he was part of that decision making. However, I think they have recognised that there is a potential risk there. They know what has happened in Belfast. They've taken advice. It was very clear from what happened in Belfast that the flow straightener was a huge part of that outbreak, and that it did need management. I think the way this is written suggests that they'd said, oh yeah, don't worry about that. It'll be part of the routine maintenance programme. Don't worry about it. Whereas actually what they needed was a very clear action to double check that that is part of the routine maintenance. And then they needed a programme of audit to ensure that it did actually happen.
And would that come about through the risk management process?
So yes, because perceived or potential, there is an absolute risk, which was well recognised, which was in the literature, which was evidence-based. The guidance had changed to accommodate that known risk, but they chose to accept that known risk. And I don't think the response that we have written there is strong enough.
If we move on to the water system as a whole, now obviously we've all heard evidence about the April 2015 DMA Canyon L8 risk assessment. I'm not proposing to go to it. And it identifies risks. To what extent do you feel comfortable about talking about the need to put a water system, domestic water system, on a risk register as something that requires, as a hazard that causes risks that requires to be managed?
So, assuming that that had been shared and that that report had been widely known about in the organisation, that should absolutely have been on the risk register.
Are you the duty holder for your hospital trust?
Yes.
So, do your hospital water systems get onto a risk register all the time, or will they only get on if they had a report like this one?
Or an identified problem.
Or identified problem. But would they be there all the time as a risk to have and manage all the time?
Not, well, at some level, you would expect to have a risk around at the estates department level.
Right.
The water management or management of the water system or so on, that there would be something there.
So you'd expect
So
that
potential failure of the management system.
So within the management structure for water, there should be a risk management process.
Yeah.
But it would only get escalated to the corporate level if there was a problem.
Yeah.
Right. In that context, the pre-filling of the system, should we see that as, or if you don't have an opinion, which is not your field, tell me. The question is whether we see that as part of, by this point, the water system as a whole, or a separate hazard that requires to be considered.
You see, it isn't it. I don't want to say it isn't. It isn't. It's one of those situations where it depends. You would naturally think that pre-filling a water system would be a risk that far ahead of it being used. But in isolation, without knowing what the management processes were around that, but it's hard to see how that early on in the construction, or that early on in the construction, that you could have a comprehensive flushing regime, checking regime, which would actually be complete enough to manage that.
The plumbing subcontractors is clear they had a comprehensive flushing regime. And we've got Mr. Poppett's report, so we'll come back to that. So are you basically on the edge of your expertise here? I'm
right, well,
we'll move on. Now, we've previously talked about Ward 4B and Ward 2A, so let's start with Ward 4B. Now, we know that Ward 4B is found to have problems with the ventilation system, not being what people expect, and after 5 weeks, the patients return to the Beatson. And then various papers go to committees, acute service committee, I think, after Dr. Armstrong revises them, and eventually the ward is refitted. And although changes are made and HEPA filters are added, doesn't meet SHTMO 301 requirements, although it's a considerable improvement. Now, of that journey, which I've summarized very briefly, where do you think it should have appeared in a corporate level risk register?
Right at the beginning.
And would it stay there even when the patients went back to the Beatson?
Yes, because you then have moving the patients back to the Beatson is part of your mitigation. It doesn't remove your risk, because you've then got to complete your mitigations and move the patients back, because the Beatson should have closed and the patients should have been in the QEUH.
So the original hazard is the non-compliant 4B, and then everything else follows after that.
Yeah.
What about the view that something like this is not a corporate level risk, although it's a regional BMT unit?
There's a lot of, one of the things you have to consider in where you put the risk is it's not just about who's responsible for it, what where it sits from the corporate management point of view. It's also about reputational risk. The reputational risk here was high because there you have a brand new hospital and you've moved patients out because it's not safe. So from a corporate point of view, I would say that is where it needs to sit, because from the corporate management of that risk or corporate oversight of that risk is going to be really important in managing how it's presented, what your reputational risk looks like, and how you manage the outcomes of that.
Is there a judgment point there? Is that to what extent is it reasonable to think that, well, you could actually just manage this within acute services or within regional sector, and it doesn't need to make its way up to board level because it's actually just being managed by the teams in those units? How do you respond to that suggestion?
I mean, you could, but as I said, where are you then going to manage your reputational risk? So theoretically, you could, of course, manage it at an acute services level and let everybody get on with it. But the oversight of how that's managed and how you deal with it and the governance around it strikes me that it needs to have that senior oversight.
Well, let's move on to Ward 2A. Now, I have to say that I'm always a little bit unclear to the extent to which people realised all the ways that Ward 2A wasn't in compliance with SHTM03 in 2015, but it wasn't, to some extent, seems to be clear. So in the summer of 2015, we know there was a discussion of risk around commencing a particular bone marrow transplant in Ward 2A in the summer of 2015 because we've discussed it with Dr. Armstrong and Professor Gibson, amongst others, and seen minutes. Should that have made it to a corporate risk register?
I think it depends exactly what was known at the time.
So, for example, we know there weren't HEPA filters in the housings. They fitted the HEPA filters. Does that need to make it to a corporate risk register?
I think it should certainly have been escalated as a risk through the governance structure. Now, whether that meant that the risk itself should be up there, I mean, ultimately, we got to the point where, of course, it needed to be because of everything else that happened subsequently. But at that point, the fact of the lack of HEPA filtration should certainly have been something that was escalated.
Even though it was fixed.
It's a significant issue with the way that the ward was constructed.
Even though, in respect of those isolation rooms, it was fixed. We got the units in from Northern Ireland, if that's it, if my memory serves correct.
But in the meantime, because that didn't just take a day, did it? So, something as significant as that, where you have to make a reasonably major change to something, even if it wasn't. I'm not suggesting that the risk should have been sitting at that level, but the governance process to raise concern should have gone up there.
Is this about making sure that it's formally reported and recorded?
Yeah.
Now, we do now know that the ward wasn't validated. But again, it's not entirely clear that was something that was understood in 2015. We had some evidence from Dr. Agrawal about, in the context of an adult patients in a BMT ward, he felt that using a ward that had an unvalidated ventilation was unsafe. But when pressed about that, he saw it was more, this was because of lack of knowledge. He did not know there might be something terrible wrong. He doesn't know, therefore it's unsafe. And I realized that validation wasn't something that was immediately cottoned onto in the Queen Elizabeth. But once it was realized there was no validation of the ventilation system, where should that have gone in terms of risk register?
So again, I would say that could I think it probably should, the conversation, the reporting should definitely have gone up to the board. And board at that point would have, well, what's happening in the ventilation in the rest of the hospital? And I would have expected that response. You know, was the ITU ventilation validated? Was the PICU ventilation validated? All of the other wards that should have had some level of specialist ventilation. That's what you would extrapolate out of that report going up. But for the actuality of it occurring, that could have initially been managed locally and at the same time as getting somebody in to validate the system.
Right. What about the awareness when it's had that the isolation rooms, the new hospital, were all built as PPVL rooms as per the employer's requirements? Once that's realised, because I know there's a gradual process of switching some of them over to different sorts, and we have that in our PPPs, but when, if at all, should that make it to a corporate level risk register?
So that again, I mean, I think by this point you're building a picture of flaws in the construction of the new build, and the reporting of all of these things should be coalescing into a board level risk at this point.
And that would involve reporting it to a board level subcommittee at the very least.
Yeah.
Now, do you recollect there was the email from Mr. Powery to Dr. Inkster and others about the air change rates in May 2016 when they find out about the derogation? Is that something you remember reading about?
I think so, yes.
Now, I appreciate that's about the air change rates we've already discussed. And you've explained that you felt that the air change rate, certainly for specialist ventilation spaces, should be on a risk register. What's the process that should be happening in terms of risk management once that 2016 realization happens, that you realize that there's been this decision at this point 7 years before that involves air change rates being lower than the guidance? What should happen in terms of risk management at that point?
So I would expect that a group would be put together to examine all of the issues together, that a comprehensive risk assessment would be done of the whole site to determine where your risk points are and to further test what the air changes actually were in reality compared with what they thought they were on paper.
Now, before we go and look at a little bit of the couple of pages on the risk register, there's obviously been 2 bits of spend on improvements to the ventilation system. One involving Ward 4B, fitted out for June 2018, and one involving the rebuilt 2A, 2B for March 22. Are those processes something that requires a consideration of risk? I mean, have you done it right? Or Or is it just all good news? You just change the scorings on the existing risks?
No, you have to, part of the process is some form of check. So you would want to get yourself into a position where let's take 2A, 2B. You'd want to get yourself into a position where you can close that risk that is related to all of the issues. You would have to have, before you could do that, the validation of the new ventilation system. You'd have to have the water testing. You'd have to have all of these things identified and the sign off, the comprehensive sign off of that as a build.
So the completion, the removal of the ward 2A, 2B risk, whatever you'd previously assessed that to be, is a risk management structured process looking at the building work. So you're checking that you've done all these things in order to remove it.
Yeah, it would be the same sign off as you do for any refurbishment.
What I want to do is show you two entries, one of which you drew to my attention, one of which I thought was interesting. So this is bundle 45, the redacted version, he says rather loudly, page 141. Now, this is a risk register from August 15. And the top row is, in fact, the Vale of Leven reports reference. It's not relevant now. It's jumping a lot on my screen. Thank you. Now, I wonder if you draw my attention to the last entry, which is 12.3, description of risk. Catastrophic event causing inability to use South Glasgow University Hospital. And why do you think that was worth considering?
The timing of this was August 2015, wasn't it?
So it's 3 months after handover.
Yes, but it was also, I thought, probably in response to moving the patients out of 4B.
So you don't know. You're just wondering whether there's a connection.
The timing is right, isn't it? The patients were only there for a couple of
I mean, it might be it was on an earlier register because this is August 15. And if you look at the one above, 12.2, disruption to services during transition to new hospitals. Now, transition had occurred by August 15. So it might be we've just not gotten one that's a few months before. What I'm wondering is whether if we can look at how you manage the idea of a catastrophic event here, and you've got a likelihood score of 3 and an impact of 5 and a risk priority and a risk rating. What I'm wondering is not to get you to assess those because that's not the purpose of your evidence, but to ask what sort of things would an entry have said around about this time dealing with what was found to be suboptimal about the new hospital? What might you have said in an entry in the summer of 15?
Sorry, I don't understand.
So if you were trying to record, you've said that the Ward 4B failings of the ventilation system should be recorded in the register. You've said the Ward 2A ventilation system should be recorded in the register at this point. And you've discussed the possibility of whether the water system might, but it's not within your area of expertise. I just wondered, when you're building a new hospital, is one of the risks we don't build the hospital we intended to build, and whether that should have been recorded in the register at this point?
I think a catastrophic event is a kind of catch-all phrase to include everything that you could possibly think of, really. If it had that impact, that you meant you couldn't use all or part of the hospital.
So you feel that's just a sort of a catch-all event that may cover a lot of things within it?
Yeah.
Right. I wonder if we can go to page 333. 333. And this is what this is from a corporate risk register in August 18. Now the date isn't here, but that is the date. Now it's risk datix ID 2190. The accountable owner is the medical director, and the description of risk is failure to implement national guidance systems and policies in relation to water safety. Now this appears 6 weeks after the DMA Canyon report emerges. And I suppose my real question is, in the way this is phrased, is this not just a generic risk around, looks like a generic risk around water? It doesn't mention the Queen Elizabeth, it doesn't mention DMA Canyon, it doesn't mention anything.
It does look generic. It doesn't describe what the risk is. So the risk is more like risk of harm to patients due to the failure to implement national guidance systems policies. And it is a catch-all thing, but the mitigation, they're not mitigation actions, they're things, they're committees, they're apart from sampling in response to clinical cases, but that kind of is a bit checking after you've got a clinical case rather than actually preventative, because what you would want is to have a preventative program in place rather than have a you need a water safety group, which should then, but these are not the actions and controls that you would expect in response to that risk.
We know that the health board set up a water safety group for the hospital, began a massive program of water testing, installed the chlorine dioxide system, and I think in Dr. Chaput's words, they carried out more water testing in this hospital than any other hospital in the UK, in her opinion. I appreciate this is only 6 weeks after they discovered the problem, and it may be that Mr. Walsh's group is still working, but would you expect to see some of these sort of things listed in the entry?
Absolutely.
What's your view? If we're right, of course, I'm saying this, that we're not going to take you to the register. That would be an inefficient use of time. But if we're right as an inquiry team to suspect that the other risks we discussed are not recorded in the register in 15, 16, 17, what would be your view about that?
I think you would have to see if they are any other risk register apart from the corporate one.
So it might be they're lower down.
Maybe on different risk registers. There may be in a state's risk register, for example, where some of them appear. But you would expect them to have been recognised and identified as risks.
Now, do we see later entries? I'll give an example of a later entry. So this is no, I'm not going to go to that one. So it might be there are later entries with more detail in the risk register. And that's good.
Yes.
But when we think about the events before the start of the water incident, if there's no mention of any of these other issues before the start of the water incident, and either they're not here or they're on a lower level risk register, do you have a view about that?
I think I think it all hinges around the non-recognition of the importance of the DMA Canyon report,
Right.
which identified the non-compliance and the issues with the water system. And I think for that to not be identified and not be recognised as a major risk, then everything else kind of falls down following that.
When you say everything else, do you mean the ventilation ones as well?
Well, the ventilation ones, sorry, I was concentrating on water. Ventilation ones, yes. I mean, from those have been recognised very early on, and you would expect to see them on the risk register.
And in terms of the DMA Canyon report, because it's not escalated, or seemingly not escalated, that may be a better explanation for its non-appearance on the risk register than anything else.
Unless you find it on an estate's risk register somewhere, but but certainly to open a hospital and have a non-compliant water system, that as it opens should be a corporate risk.
What I want to do is go back to your report. So that's volume 44, volume 6, page 10, and to continue looking at
Sorry, I think it's entirely my fault. It seems quite clear that the DMA Canyon report was instructed in 2015, but then lost sight of and only came to the attention of anyone who did anything about it in about June 2018. Now, it's just to understand Mr. McIntosh's questions and your answers. The question was, if before the start of the water incident, so I take it that's March 2018.
Yes, indeed, my lord.
It was not on the corporate risk register. Any view about that? And I've noted you were saying it all hinges on a non-recognition of the importance of the DMA Canyon report. I'm just not...
I'll turn it into a question, my lord, maybe my mistake.
Right, okay.
To what extent does the fact that any high risk of any level arising from the water system, whether it's pre-filled or the horn taps or any of that stuff, is not on the risk register prior to the start of the water incident, is in fact that largely will be explained by the fact that it wasn't escalated within the organisation?
Yes, I think so. Because if it's not escalated within the organisation, then nobody has oversight of it, and nobody is ensuring, even though there is a water safety group and that's what they should have been doing, nobody is checking that all of the management of that system is to plan.
Thank you. I'm proposing to go to page 12 of your report and look at your conclusion. But before I do that, I want just to ask you a couple of questions about safe again. So if I recollect what you were saying before, that something is unsafe if there is serious consequences which have a higher prospect of happening. You're nodding.
Sorry.
But if we go back to the original part in your report, which is the process on page 5, just to recap, we had at 4.1 identify the hazards, 4.2 determine who might be harmed, 4.3 evaluate the risks, 4.4 implement measures to minimize the risk, and then you've got 4.5 over the page record the significant findings and review and update. I think your evidence was that somewhere in that process of choosing the control measures and implementing them, you're deciding on your tolerance of risk.
Yes, I think you have to have all of your information in place
before you do that.
So you need to know what your risk assessment looks like. You know what the findings are. You know what the control measures that are available to you are. And then you can put that together as to what risk you're willing to tolerate.
Now, if you decide as an organisation through a process fully informed with all that assessment
Yeah.
that you're prepared to tolerate a particular risk, is it ever fair to describe that hazard as causing something that's unsafe?
So unsafe in the moment, or unsafe because you're willing to accept an unsafe level of risk?
Well, to some extent, is this in an internal logic that if you go through a proper health and safety risk management process,
Yeah.
you decide the hazard, you review the hazard, you identify the risks, you look at your mitigations, you apply the mitigation chart that's in front of us on the screen, you come up with a plan,
Yeah.
and you decide what risks you're going to tolerate. To what extent is it legitimate to criticize what comes out of that as unsafe, to sort of second guess the process?
It's not necessarily your outputs that's unsafe, it's where you start that will be unsafe.
But if you do all these things, so if you start with something that if you didn't address it would be unsafe, and then you take all the steps necessary, and you decide to tolerate a certain level of risk, and you reach a conclusion, will that now be safe?
But you said will be unsafe if you don't address it, but actually it is unsafe at that point.
Right. So if you have a hazard that is unsafe, that you assess, identify the risks, you choose a mitigation strategy, you decide what risks you're going to tolerate, you then do that, is it ever still going to be unsafe at the end of that process?
It will continue to be unsafe until you manage to bring the risk score down. So it may be that it takes time to affect the risk score. So your mitigations may take time to implement. They may, and you may have to put other systems in place. So it's like, can you fix a water system? Well, we can, but it's going to take a lot of work and a lot of time. Well, actually, so we'll put filters on all the taps as a mitigation, but that doesn't stop your water system being unsafe in the meantime. It just means that you are protecting your patients
from an unsafe water system.
Yeah.
We go back to your conclusions on page 12. So in paragraph 26, this is effectively your replacement, the definition that we had sent to you. So you're no longer saying is unsafe and unmitigated avoidable risk to patients. You now have a more complex idea that you consider whether all risks have been recognized, whether those risks are mitigated to an acceptable level, are being actively managed. That's your definition of unsafe.
Yeah.
And so something that, if unaddressed, would be unsafe can be made safe by being recognized and then having its risks recognized and those risks mitigated and actively managed.
Yeah.
And then you then have something at paragraph 30, which strikes me as possibly new. So I wonder if you take me through what you're saying at paragraph 30.
So the most recent data that we were given on bloodstream infections was for the first 8 months of 2023.
And this is an extension of your 214,000 row spreadsheet, effectively.
Yeah, which wasn't used in the calculations and the chart. It just went up to 2022. But the data that we were given shows that there are still infections with environmental organisms. Now, that doesn't mean that it's not safe,
Right.
because we know that there is, that other similar units are also seeing a level of infections.
Because that's what Mr. Mukherjee's study told us.
Yes, exactly. And we know that the lines cross, and they get the Shehalin unit rate is well down compared.
And in
with
fact,
the
maybe
comparator
lower than
units.
some of the comparisons.
Yeah, by 2022. So the question is everybody happy with that? Do we recognise that the risk is being managed? Do we recognise that mitigation has been put in place, engineering controls have been put in place, and that we have got that rate down to as low as we think that we can reasonably expect to go?
And so what's your view about the extent to which that might be the case?
Well, I think if everything remains as it is, so the rates remain where they are, or go lower, that the water continues to be managed, that the management system is stable, is that the testing continues and doesn't show up any weird things, or unsafe levels.
When you say
of
weird things, you mean the organisms?
Yeah, so unsafe levels of organisms, and stays within the expected parameters, then I think you can say that from that point of view that it is safe.
Because you've applied that logic of thinking about
Because
what the risk is.
you're doing everything that you can to prevent the infections.
Even if it wasn't put on the risk register at the time you'd like it to have been put on, you can still say that it's now not unsafe.
Yeah.
So to some extent, this discussion about risk register is not definitive. You can have something that's not on the risk register and be concerned about that, and yet the problem is actually being managed in reality, just not through the risk management process.
Yes, you can. It's not ideal.
Why is it not ideal?
Because it doesn't give you visibility, and it's not the best governance process if you have something that's happening on the side but you don't recognise it in your risk register.
And also, would it make it harder for the fact that you're doing it to be known, as it were, at the part of your board minutes that make it into the public domain?
Yeah, yeah.
Well, this is probably a good time to stop for the lunch break. I just want to indicate for my colleagues, that was me probably at the end of my section on risk, and I would be grateful if anybody has any Rule 9 questions on risk to immediately get them over the lunch break, because it means I can do them straight after lunch. It might help logically.
See, that might make sense. We'll take our lunch break now, Mumford, and try and sit again. Good.
Okay.
Stands.